G'day and welcome to Emergency Topics. In one coffee, I'm Giles, an emergency physician, and today's topic is going to be how to present a patient for admission when you're working in ED as a doctor to an inpatient consultant. Now, if you work in Australia, you'll be aware of that handover, a mnemonic ISBAR, introduction, situation, background, assessment and recommendation. Now, this is excellent for handover amongst peers, or handing over to another doctor at the end of a shift, or even handing over to the ward. But when you're trying to sell a patient to an inpatient consultant, I think it falls a little bit short. So I'd like to present to you a slightly different mnemonic, doing 6 Ps. So those 6 Ps are prepare and predict, present yourself, the patient, the problem, the plan, and finally the pact. So what I'm going to do is I'm just going to expand on all of those 6 Ps and then show an instructional video. Enjoy. Prepare and predict. Get your information together before you call. Rehearse in your mind what you're going to say and predict the likely response. That is, know the consultant's personality. Think, what are the barriers they will see to admission from their side of the fence? Present self. Identify yourself by name and role. For example, hi, I'm Giles, the emergency registrar on Today in ED, and I want to have a chat to you about a patient I'd like to admit under your care. This way, the inpatient consultant, who may take call at a number of different institutions, knows who you are, your seniority, and where you're ringing from. Also, by saying early that you want to admit the patient under them, the ground rules are set. Patient. What sort of organism are you selling? This is all about risk and pre-test probability. Think about these two 45-year-old men who present to the ED with central chest pain. The first is previously well with no medical problems or cardiac risk factors. The second has a background of hypertension, diabetes, morbid obesity, previous stents and a VF arrest. Same presentation, but with very different pre-test probabilities of their chest pain being ischemic in origin. Problem. The problem is a combination of the history, examination and investigations you have done. This is the main part of your sell. You are transmitting the evidence that this patient is appropriate for the inpatient consultant and requires inpatient care. Plan. This is telling them what you are looking to do and also what you want them to do. An example would be, say, a 45-year-old man who presents with chest pain and has anterior T-wave changes on his ECG. So, I've given 300 milligrams of aspirin and clopidogrel. I'm awaiting a chest x-ray. The initial troponin is elevated and I've started some GTN for his ongoing pain. I'm looking to put him in CCU and start a beta blocker. What else would you like? Pact. This is where we close the loop on the conversation. It's very important to make sure both you and the inpatient consultant are in agreement. So, after you have listened and agreed with the inpatient consultant on the care plan, reiterate the pact. For example, I'll put them under your care, chase the chest x-ray and start 50 milligrams metoprolol BD. I'll give your registrar a call and she can see them either here or in CCU if a bed becomes available. Okay. Now let's see that framework being used in a simulated scenario. Hello. Dr. Lindgren, it's John Cameron, the CMO in Campbelltown ED. Could I chat to you about a patient I'd like to admit under your care?
Sure, go ahead.
Her name's Joan Moorhead. She's a 62-year-old lady. She comes in with bilateral pneumonia. And she's been previously well as a non-smoker and lives at home with her husband. No significant other medical problems apart from some diet control, diabetes and hypertension.
Yep.
Over the last 4 days, she's become increasingly short of breath. She's had some sweats, she's had some shakes, and she's been coughing up green sputum. And now she's short of breath on walking only 20 metres.
What does her examination show? Her investigations?
Mrs. Moorbank saturates 94% on 3 litres nasal prongs, but she was 90% at triage. Her heart rate's 104 per minute, her blood pressure is 116 on 70, and she's got a temperature of 38.2. She doesn't look too bad. She's got a respiratory rate of about 34 per minute, and she's got bilateral coarse crackles in the mid zones mainly. The rest of the exam's fairly unremarkable.
Chest X-ray?
Bilateral consolidation. The only bloods we've got is a mildly elevated white cells at about 14. The UEC's are normal, CRP is still in the pipeline. I've taken some gases. pH is mildly alkalotic, and the PaO2 is 70, PaCO2 is 32.
Those gases don't sound too bad. How about we try a couple of nebs over the next couple of hours? She should be ready to go home.
Those gases are on 4 litres per minute. She's got a respiratory rate over 30. I'm sure she's going to have to come in. And I've started, therefore, some IV ceftriaxone and some oral azithromycin. Look, at the moment I'm clinically reasonably happy with her. We're pretty tight down here, beds-wise. If it's okay with you, is it possible that I might be able to move her up to the ward and your team could review her?
Okay, could you send off a sputum, make sure you order a Legionella and Mycoplasma PCR, and I'll get my reg to review.
Okay, so I'll admit her under your care. I'll get a Mycoplasma titer added, get a Legionella PCR and get a sputum culture, and then onto the ward and your team can review them there. Yep?
Good, that's fine.
Okay, look, thanks Dr. Lingham. Cheers. Thanks, bye. Well, I think that'll just about do for how to present and get admitted an emergency patient to an inpatient consultant. Hope you enjoyed it. I'll see you all next time. Cheers.